Good afternoon, everybody. Welcome to the second day of the People to People and Ministry of Health conference. This afternoon, the conference is going to be on flow cytometry, practical exposure into the use, the clinical use, the application. We will hear from two experts in the United States, as well as one hematopathologist from St. Paul who has experience, who will be talking to us. So the first speaker for this afternoon is Dr. Chen from the Mayo Clinic. He's the director of the pathology laboratory there, a hematopathologist. Dr. Chen, you can hear me? I want to make sure.
Yes, I can. Yeah, thank you.
Fantastic. Welcome. Thank you very much. I know it's early morning for you there, so thank you for joining us. We appreciate it. So he's a hematopathologist, and as you know, flow cytometry is incredibly critical and integral to the diagnosis of hematological disorders. So in the effort to start a hematology oncology fellowship at St. Paul, one of the most important things that is needed is going to be a very good supportive diagnostic capability, of which flow cytometry is going to be critical. So Dr. Chen, he gave us a wonderful talk yesterday on the Hematology Oncology Fellowship, its benefits, some of the plans, which was very exciting and wonderful, and I thank you for that. So I'm inviting you now to give us a talk, and the title of his talk is Application of Flow Cytometry in Hematology. Again, thank you for taking your time so early in the morning. We appreciate it. We enjoyed your talk yesterday and looking forward to hearing from you.
Yeah, thank you so much for the kind introduction. So first of all, I apologize. I couldn't be there in person. My wife had an accident, and then I have to take care of her during her recovery. But next time, looking forward, next time I can be on site to talk to you all. So today, we have three speakers. So first of all, I want to thank the other two speakers. Dr. Masfin is actually local from St. Paul, and then he will share his training experience regarding flow cytometry. And then Mike Tim is our colleague at Mayo Clinic. He probably single-handedly developed all of our flow assays. So he's the real expert. I'm just, I call myself a super user, and then use these panels to diagnose hematologic neoplasm. And so they're going to give us talk. And then really the overarching goal is to start the dialogue, potentially developing flow cytometry practice in Ethiopia. And then we want to share our maybe plan or strategy downward towards this goal. So my talk, let me share my screen. Yep. Can you see my screen?
Yes, we can.
Okay, so great. So no disclosure. So really the three goals. So number one is I know you have heard about Mayo Clinic. I just want to give you a high-level view of who we are and what we do. Second part is the flow cytometry practice. And also, I also introduced in the middle of my talk about potential roadmap moving forward on how to introduce this as maybe a routine testing in Ethiopia. So Mayo Clinic has a large operation in laboratory medicine. So we have about 245 pathologists, and also about 4,000 technologists. And then total right now, we have about 3,000 to 4,000 laboratory testing items. And we develop about 100 tests per year. And then our publication is about 500 per year. And then at the same time, we have close to 100 what we call the laboratory developers. So their job is to develop a new test to provide this service to our patient care. And then we have 9 divisions and then 63 laboratories. Hematopathology is one of the division. Itself contains 5 laboratories. Cell kinetic is a fancy name for flow cytometry. And also we have a morphology laboratory. Metabolic laboratory is more for red cell disease and other benign hematology disorders. And then molecular hematology laboratory and also special coagulation. So in our division in Heme, we have a 43 we call pathologists or physician. There are 28 pathologists and 6 cytogeneticists and also 9 clinicians. They're mainly covering benign heme and also coagulation. And then we have about 240 allied health staff. They spread in management, support, and also laboratories. So really our practice in summary can be grouped into lymphoma, myeloid, and benign heme. And then as for the malignant heme, as you know that this is actually published by American Cancer Society. This prevalence of the disease probably reflect in many different areas. And then really hematologic neoplasm represent about 7% of a total cancer in US, and most likely also in the world, about I would say 5 to 7% range. So really, as a pathologist, we are working on really the diagnostics and then the journey of the patient, meaning diagnosis, prognosis, treatment, and monitoring treatment. In nowadays, usually they can summarize into MRD testing. So as for the diagnostic and prognostic myeloid, this is the beginning of the case. This is bring us to why flow cytometry is so important. So we do usually work up these cases in 4 categories or 4 steps. One is morphology, one is immunophenotyping, one is cytogenetics, and then molecular study. So today we'll be focusing on the second step is usually the immunophenotyping. In hematology, we do both immunophenotyping by flow cytometry or staining by immunohistochemistry. So, so as you can see that flow cytometry is a crucial step or a test in the early diagnosis and the classification of diseases for myeloid neoplasm. For lymphoma, this is the same. So similar morphology, immunophenotyping, cytogenetic study, and the molecular study. And for the immunophenotyping, flow cytometry is also important for diagnosis. And also nowadays, flow cytometry is becoming more and more important in minimal residual disease monitoring. Minimal residual disease is a disease state that maybe morphologically and hematologically patient appear to be in remission. However, if there's any low detectable disease by flow cytometry or molecular method, usually the patient have a much higher risk of a relapse. So as you can see that flow cytometry is still very high on the list and it's an early test in diagnosing and managing patients. So here is a potential roadmap. This is still a brainstorming session, meaning we're going to this is a continual conversation, and then gradually we're going to see whether this is actually feasible, and then we are willing to adjust and then to act accordingly. So we're thinking about implementing flow cytometry in 3 phases. Phase number 1, the goal is actually to implement feasible, simple assays to take care maybe 90%, 80 to 90% of the cases using existing platform. I know in Ethiopia, the most common platform is a BD caliber flow cytometer. This is the principle of this, or the major use of this right now is for the T cell counting, CD4 and CD8 T cell counting for HIV patients. So therefore, this one, if we have reagent cocktail and also SOP available, these could potentially be used as the first phase. The first phase, we're thinking about developing or implementing triage panel that we use at Flow at Mayo Clinic. This triage panel, which I will touch upon in my talk and also in my team's talk, is really the initial testing. We can use that to differentiate whether the patient has a acute leukemia or lymphoma. And then that's pretty much give us a general idea. And then with morphology, I think that will probably meet the current need, urgent need And then we move on to, that's phase one. We're thinking about maybe using one of the institution, one or two as our pilot site, and then work closely with us to develop this. And then we have received approval from Mayo Clinic to release our SOPs of this particular caliber SOPs of triage panel to be implemented in other laboratories. So phase one, so once we establish this, and then we're thinking maybe we start to move into phase two and phase three. So we know the AML, if we can pretty much diagnose acute myeloid leukemia, and then for that group, cytogenetics and the molecular would be the important. And then we feel that the phase two, which will take a year to accomplish, would be more sophisticated panel to address B cell and T cell lymphoma. And then I'm not too sure about the B cell lymphoma prevalence. We're thinking about maybe Burkitt's lymphoma or some B cell lymphoma may be common. So that's we're thinking its B cell panel would be a focus. So because of the nature of B cell and T cell panels, there are a lot of antibodies involved in further classification. We felt that at this moment, maybe caliber maybe may not be the ideal instrument. For this one, we're thinking about a BD Canto 2 or Canto. This instrument is slightly more expensive than caliber. And then we felt that we will hopefully obtain one instrument and then be able to, just like we plan to for the caliber, to establish in one hospital and then gradually build a TB panel. And then phase three will be, in a sense, complete the diagnostic journey of the flow cytometry. We're expanding the more comprehensive leukemia panel. This is usually for phenotyping and to provide a more kind of the markers for acute myeloid leukemia. In addition, these panel can be used for myelodysplastic syndrome diagnosis. But right now, the flow cytometry for that purpose has not been accepted by WHO. So in a sense, it's more like a plus panel for acute myeloid leukemia. And then last but not least, multiple myeloma is also a common disease. And so, but itself need a sophisticated panel and also wet lab process because plasma cells intend to die during processing. So therefore, we felt that this is because of the demanding nature of these two panels, we felt that it may be the best to put into phase three. And also we know that after phase one and two, we probably establish two things. One is a good experience on how to implement these assays in Ethiopia laboratory. Second one, would be that we probably already established a good partner relationship with a couple of institutions or one institution. So make the future more complicated or complex panel more easy to develop. So that's, again, this roadmap can be changed, can be adjusted. So we felt that in the phase one, we're thinking using calibers, which is somewhat widely available in the country, and then use a simple approach to deploy flow cytometry panels in as part of the routine hematology testing. So now I'm switch gears into flow cytometry about a 101 of why flow cytometry. Flow cytometry is actually a unique method to measure single cell. So it's basically create a flow of single cell, and then there's a light and fluorescent detection, and then we use that to tell the immunophenotype of a single cell. So here is a diagram of the flow cytometry. So really the technology is using a sheet fluid to create a single cell flow, and also use a sound wave to focus this event. And then there's a laser to shine on the single cell, and then they produce either the optical signal or fluorescent signal that can be detected by the flow cytometer. So here is a video is showing the example of a acoustic focusing. So without focusing, actually you can see this is even sheath fluid focused. single layer. There's no way for laser actually to focus on the cell. So this is showing a mechanism of focusing the single cell in the flow cytometer. And then, as a matter of fact, of all of this focusing mechanism and also the compensation mechanism, even though BD caliber appear to be the older generation instrument, but of all of the mechanism, BD caliber appear to be superior in the mechanical part of the flow cytometer than even the current flow cytometers. So here, and then we shine the laser light, and then we usually have the forward and scattered light. Forward usually is a forward shadow of the cells, and then the scattered meaning if there's any granular in the cytoplasm, they're gonna deflect the light, so give a side scatter, and then we plot them. This is one of the most important 2D histogram of flow cytometry. So and then if we use a fluorescent, and then we can use the UV light to shine the laser to the cell, and then to get a fluorescent signal. And then we can actually label the antibody with different fluorochrome, and then they all have a different spectrum wavelengths, so we can use that to detect different signals. So because of as you can see here, the fluorescent signal is a kind of a broad, and then they have a spectrum. So therefore, even though we're looking at this, we have to do compensation. I'm not expert of the compensation. Mike will touch on how to do the compensation, because without that, we can easily get error in the flow cytometry results. So once we have all of this done, each cell will generate a signal with multiple parameters in this. And then the caliber we use, usually we have 2 lasers, meaning 4 colors. And then we can actually use different cocktails to use 4 color. For instance, 2 tubes will give us 8 colors, but usually we use 1 color to kind of link the population. Usually that's a 45. And then we will be able to, maybe 7 antibodies, 2 tubes will be able to resolve many of the, I would say 80% of the cases. So once we have the flow cytometry running, and also we have the fluorescent, as you can see, we can plot them in this 1D histogram. So in this 1D histogram, you can see that the fluorescent is on the x-axis, and then the cell count is on the y-axis. So here you can see a signal on the right side, and then this is indicating for this particular antibody, there is a signal. And also we know the cell count, we know it's about 16% of the total cell. And then at the bottom, there's the table showing if we draw a threshold, how many cells actually can be negative and how many cells can be interpreted as positive. And then from this one, you can see that really that the numbers and then compensation for each cases can be different. And also when we draw the lines, sometimes it can be arbitrary. So there's a tremendous experience and also reagent to reagent differences, and also significant training needed. So once we have the 2 markers, when we look at them, we plot them into the 2D, we call it dot plot. And in this dot plot, we have the x-axis and the y-axis, and then they are both presenting 2 antibody, y-axis presenting 1 antibody, and then the x-axis representing another antibody. And then the cells are, because of how they express these 2 markers, they can be present into these 4 quadrants, representing the possibility of the expression of different cells. For instance, in the upper right quadrant, and then these cells are expressing both. Well, in the lower left quadrant, the cells are not expressing any markers. So, and then you can have this table in the bottom showing the distribution of this event. This is extremely important, this 2D histogram for us to interpret cases. However, we are now moving into multiple dimension using AI mechanism to really to look at the event in a 3D is no longer is limiting us. Actually, it's we can look at sometimes multiple dimensions using clustering mechanism to do the flow cytometry using AI mechanism. But for us, for visual inspection, these 2D histogram is the most important kind of the histogram in flow cytometry. So as you can see here, this 2D, and then for 1D histogram showing us the nature of the each antibody when we put them together in the 2D bivariate plot. So as we see, this is actually an example of the 2D histogram. And then the parameter of this is the x-axis is called a forward scatter, which is meaning usually remember the forward is representing the size of the event or the cells. And then the side scatter is the granularity of the cell. So by doing this plot, you can see that on the x-axis, the more on the right side, the bigger the cells. And on the y-axis, the higher the number, indicating more granular of the cytoplasm. So by doing that, we can see that A is the smallest cell without granules. Those are lymphocytes or lymphoblasts in the histogram. So that's basically just looking at that, we know what kind of a cell they are without even immunostaining. And then the monocytes, they're larger, so they're on the B. And then they don't have a lot of granules in the cytoplasm. However, they intend to be membranes are wrinkled because they're having more cytoplasm, and so therefore they're slightly on the side scatter. They're slightly having a higher number, and then the largest and also have a lot of granules are granulocytes. So therefore they're in the C. So this is the forward and the side scatter histogram is the most important in flow cytometry. So now we know all of this, and then we want to address what are the potential applications of flow cytometry in our flow laboratory. So obviously, number one is diagnosis. Number two, we sometimes can use that for classification. I will have some examples. These classifications are more important in leukemia and also in B-cell lymphoma and sometimes T-cell lymphoma. And then they can provide prognostic factors such as CD38 in CLL and ZAP70 in CLL. And then also they can be used to assess the therapeutic target, for instance, CD20, CD22, CD33, and CD52. There are targeting therapy targeting these markers. We run these flow cytometry to give us a marker so that before we treating the patient, we know patient's leukemia, actually leukemic cells express this marker. And also residual disease monitoring, this is becoming more and more routine in our laboratory. And also there, in other part, this has been used for histocompatibility for transplant. And then this slide is really in infectious disease because the CD4 and CD8 can be very helpful to diagnose patients with risk of infection. And for instance, the HIV and mycobacteria infection, there are usually the risk of infection is related to the CD4 T cell count. I would not dive into too much because I believe that many of you are expert on this and also are currently running these assays. And then this is a histogram from the caliber using the caliber, and then this is a CD4, CD8 assessment. So basically, the site and CD45 scattering. This is showing you the gating on the lymphocytes, and then once the lymphocytes are gated, and then they're further gated for CD3 positive or CD3 positive or CD3 negative T cells, and then they be analyzed in another tube, CD8 and CD4, and then we can get the CD4 cell identified, and then we just count the percentage, and then we can get the percentage number, and also we can count the cell number either through flow cytometer or cell counter to be able to tell finally the CD4 cell number. So I feel that if a laboratory can perform this, I believe that they only need a SOP and a cocktail, and then a triage panel to diagnose acute myeloid leukemia, and majority of or differentiating lymphoma versus acute myeloid leukemia is quite possible, and it won't be too much more complex than this analysis. So now let's differentiate. The first number one flow cytometry's goal is to differentiate whether the abnormal cells are myeloid or lymphoid, because the treatment and diagnosis are vastly different between these two groups. So for the myeloid markers, now recognize there are CD13, 14, 33, 36, 40, 64, CD117, and a myeloperoxidase. And myeloperoxidase is actually a cytoplasm stain. The remaining stains are mostly surface stain. Lymphoid, for the T, the most definitive markers are surface CD3 or cytoplasmic CD3. For B cells, they are surface CD19, 20, 22, 24, CD79A. So these are the markers that we use to differentiate or define lineage. So the parameters that when we run this lymphoma and acute myeloid leukemia measurement, they're usually like we said, the size, the granularity, the fluorescent expression, and also DNA content. DNA content have usually two applications. We use DAPI as a fluorescent dye which stains DNA, and then we use that to many times we add this into a flow to adjust or assess quality of the cells. So normally, if a cell is not broken, it's intact, when we stain the dyes, the dye will not be able to penetrate the the cell membrane, so the cell should be negative. But if a cell is staining it, usually meaning the cell is no longer viable. That's one application. The other one is we use that for the DNA content for multiple myeloma, and sometimes for BAL for assess the diploidity or chromosome content. So side and forward is one, and then the other most important gate is CD45 and the side scatter. So as you can see here, these basically tells us the pretty much the distribution of the cells in this. So we have the lymphocytes, we have the monocytes and the granulocytes. This is from a peripheral blood. In the bone marrow, we have lymphocytes, monocyte, granulocytes, and then in the middle here is the blast, which is I call the gate of the interest, meaning this is really the blast population going to be end up into here. And lymphoma will be ended up usually in the lymphocyte gate. So here, the gating will be very important. So by drawing the gate and then looking at other expression, this is actually our triage panel. So for this case, we have these three populations. So we have lymphocytes, monocytes, and granulocytes. And then we have the blast gate. We call it CD45 dim gate. So, and then we can tell, so if we gated on these lymphocytes, we can and then look at in another 2D histogram CD39, CD19 and CD34 here, and then we can assess blast. So if it was a leukemia, the blast will be here. If it was a B-ALL, the blast will also carry CD19. So we can easily tell whether the blast is a lymphoblast or myeloblast. And then we can also gate it on the T cells, the same lymphocyte gate, and look at CD3. We can look at CD3, and then for the I think this gate here is actually the CD16. This is really the NK cell gating. And then we can also gate it on the lymphocytes, and also further gate on the CD19 cells, and then look at the kappa lambda. We will be able to tell whether these B cells are clonal. So just see by doing this, we can tell if there's any increase in CD34 positive blast, and then whether there's any clonal B cells, and then what is the population of the T cells, and then if there's a lot of NK cells. These covers about, I would say 80% of the cases in the beginning to give us a general idea. This is our triage panel general idea about where the case is heading to. And then we add a more sophisticated panel. So really, we just talked about, so the flow cytometry can do B cell, NK cell, plasma cell, leukemia, and then some benign and PNH by flow cytometry. So for the B cells, the most important antibody we use are CD5, CD10, and CD103. So very simple. So CD5, we have a list of diseases here, CD10, and then CD103 are mainly hairy cell leukemia and marginal zone, splenic marginal zone lymphoma. And then for CD5, we're talking, and in this particular lymphoma group, the most common ones are CLL, chronic lymphocytic leukemia, small lymphocytic lymphoma, and the mantle cell lymphoma. These are the most important and distinct and more common lymphoma. So the flow cytometry is perfect for these two. And then there's other maybe have a partial CD5 staining for in marginal zone lymphoma, lymphoplasmacytic lymphoma, and large B-cell lymphoma. They do express CD5, but they're not very specific. They usually cannot be easily diagnosed by flow cytometry. So here, to differentiate the most common CD5 positive lymphoma, here's a diagram of a CLL and a mantle cell lymphoma. For CLL, the surface light chain, meaning the kappa lambda, intend to be dimmer in the CLL and SLL. For CD20, and then CD20 intend to be dim in CLL. And then CLL cells intend to express CD23, which is negative for mantle cell lymphoma. And also another marker called the CD200. CLL intend to have a very bright CD200, while the mantle cell lymphoma mostly very dim or negative. So therefore, by doing flow cytometry, we have a pretty confident kind of feeling about whether to differentiate CLL versus the mantle cell lymphoma. So here is an example of a CLL. Again, CD45 and side scatter. We're gating on the right population, which is lymphocyte gate. And these cells are expressing CD19. We know they're CD19 because they're B cells. Now the software painted these B cells into a red color, and then they are CD5 positive. And then they are CD20. You can see these population. So they are so they're painted. The red is for the kappa restriction. As you can see, this green and the red are meaning polytypic B cells. They're CD20 positive, but the tumor lymphoma B cells, you can see they're dimmer on the CD20. That's a feature for CLL. And then they also co-express CD23, and then they're kappa light chain restricted. Here is another example of showing the dim CD20. And also they are negative for CD38. And then CD200 is showing a very bright population. So this is a diagnostic for CLL. usually we just call out straight without further kind of additional testing or immunostains. Mantle cell lymphoma, very similar pattern, but not identical. So gated on the right lymphocytes gating, CD19 positive gated, and then they're painted red because of their kappa. And then there's CD5 bright and bright 20, and CD23 negative. And then here they're showing CD38 being positive, and then CD200 is dim or partial. So these one we usually favor mantle cell lymphoma, and because these still can be something, but very still pretty high confident that this is most likely a mantle cell lymphoma. To diagnose this, flow is for definitive diagnosis, flow is a good tool. However, we do need immunostains on the tissue or bone marrow or tissue or fish to define the CCND1 IgA fusion or cyclin D1 co-expression. So for the other CD5 non-specific markers, I listed a paper published by our group a long time ago, and showing the distribution of these cells. And then again, we just talked about more popular CLL, but there are mantle cell lymphoma, LPL, and other disease can actually also have some CD5 co-expression. So CD10 positive cells are mainly follicular lymphoma, DLBCL, Burkitt's lymphoma, or Burkitt's-toid mantle cell lymphoma, and then they can express CD10 and being CD5 positive at the same time. So here, as you can see, this is already painted the copper light chain restricted B cells to be red, and then they express CD20 and then CD5 being negative, and then here as showing CD10, CD5 gated approach, and then you can see this these cells are co-expressing CD10. So and then they are, I think they are negative for CD23. So we however, even though we know these lymphoma cells express CD10, we cannot tell many cases whether they are follicular lymphoma, DLBCL, Burkitt's, or blastoid mantle cell lymphoma. CD5 can be a hint, but the flow cytometry can only diagnose, we call it a CD10 B cell lymphoma, but it still rely on the tissue and other method to for further classification. So hairy cell leukemia is another interesting lymphoma. It can be easily diagnosed by flow cytometry. So again, first one is gated on the lymphocytes. And then now the green color is painted for the lambda light chain. And then you can see that they are CD19 positive, CD5 negative, and then they have a bright CD20, and then they are lambda restricted. And then the distinct marker is they co-express CD103 and the CD11C. So by co-expressing this strong marker, it's actually it's pretty specific for hairy cell leukemia. But sometimes the splenic marginal zone lymphoma can express some CD103. So what we do is we introduce CD200. So CD200 hairy cell leukemia also is the lymphoma that has highest expression of CD200. If you rank it, the number one will be hairy cell leukemia, the number two would be CLL. And then, however, splenic marginal zone lymphoma should only have a dim or negative CD200 expression. So that's another way to differentiate hairy cell leukemia versus splenic marginal zone lymphoma. We also use chemical stains called a trap stain to diagnose the hairy cell leukemia, and also for the splenic marginal zone lymphoma, they should not have a lot of the trap positivity. So I listed other method here at the bottom to differentiate these two very close related kind of lymphoma. So T cell lymphoma, we identify using CD2, CD3, CD5, CD7 co-expression. And also we use CD4, CD8 ratio, and we can further classify them into CD4 positive, CD8 positive T-cell lymphoma. And also we, in our cocktail, we assess if they are expressing gamma delta T cells. So here is the CD4 positive T-cell lymphoma. And then again, first gate down on T cells, we look at whether they express CD3 positive. For these T cells, apparently they have a dim CD3 surface. And then they are expressing CD5, and then they're expressing CD4, they're positive CD7, and they are nuclear TDT negative. This marker is really for the TALL leukemia. And then they are, we also have the cytoplasmic myeloperoxidase to differentiate from the potential T-cell marker expressing acute myeloid leukemia. So CD4 positive T-cell lymphoma, they're more common in T pro-lymphocytic leukemia, and however, most common is actually Sézary syndrome. It's a mycosis fungoides. They usually have CD7 negative phenotype. And also we can diagnose CD10 positive T follicular helper cell lymphoma. And acute myeloid leukemia is a very common flow and very important. We talked about really the number one is to differentiate myeloid versus lymphoid. In this case, we use the markers that B cells are CD19, 20, and 79, and the T cell CD3, and myeloid. The most important marker is the myeloperoxidase, but we have other myeloid markers such as CD117, CD13, CD33. And then for the leukemia, so we really look at the B-ALL. Interestingly, B-ALL is the leukemia that have a very dim CD45. So as shown here. So this in our blast gate, they usually drop to the bottom. So this is a good indicator for B-ALL, and they express CD19, and then they are also express CD34 and CD10. They intend to be nuclear TDT positive. So by doing this, it's pretty diagnostic for B-ALL. And then B-ALL sometimes can be confused with hematogons, especially in pediatric patient population. They appear to be actually a spectrum of differentiation. And then if you look at CD19 and CD34, they have the spectrum of this curving differentiation. And then, but usually they're more scattered. They're not a uniform population. By looking at these kind of a distribution, we usually can tell if we're dealing with hematogon hyperplasia versus B-ALL. So this is an example of a T-ALL. And then, like I said, this is actually all gating on the T markers. And then they can be surface CD3 negative in this case. However, in this case, they still express CD2, CD5, CD7. And then they're not expressing CD4 or CD8. They intend to be dim on 45. And then they have a much stronger TDT to show their really the TALL. So because some of the myeloid leukemia can actually express, let's say, CD2 or CD7 sometimes. So really, in many cases, the TDT is a good helper and to tell whether this is a TLL or versus AML. However, it's not too specific for that purpose. But for all TLL, they should express nuclear TDT to differentiate from mature T-cell lymphoma. Another organ is the thymus, and then they intend to have these immature lymphoblasts in the thymus tissue. They have a similar immunophenotype as the TALL leukemic cells. They also express TDT. However, they have the spectrum of CD3 expression, and also they usually more scattered rather than a focal population. And also it's in the right tissue. So therefore, when we are dealing with a thymus tissue, we intend to be more careful not to overcall TALL. So here is example of AML. So again, these the gating is showing you the scattered and the CD45 distribution of this, and then showing first number one is the gated on the blast, and then look at remember that we talked about gated on these gate CD19 and CD34, and then you know, okay, now this is CD34 not expressing CD19, so suggesting this is most likely a myeloid leukemia. And then look at the other myeloid markers. For this case, the blast co-express CD34, CD117, and then there's maybe a spectrum of CD33, and they express CD13, HLA-DR being positive, and then there's some partial expression of both myeloperoxidase and TDT. This is the example that TDT can be helpful, but not too specific to differentiate myeloid leukemia versus TALL. And then the most important, I think, the flow cytometry and then also morphology is the acute promyelocytic leukemia. So they can be easily spotted by flow cytometry and of course morphology. So again, our most important gating in the CD45 and side scatter. So they intend to be overlapping with the monocyte or granulocyte gate. They're very high up. And then the blast gate is right here, but they're more on the right upper part. So that's a first hint. Second one is they intend to be CD34 negative. And then sometimes CD117 should be partial or positive. And also they are HLA-DR negative. Many of the acute myeloid leukemia, they should be HLA-DR positive. So that's a good indication of APL. And also they have a uniform CD33 and CD13 positivity. So that's a good hint. This pattern is a good hint for acute promyelocytic leukemia as listed here. Once you have this kind of the indication, and then you pretty much pull the slides, or before even the flow, you look at the slides, you see these R rods, and also lots of R rods, we call it Foggett cells. And then that's pretty much we have very high confidence that we're dealing with acute promyelocytic leukemia. That's a medical emergency. We need to inform our hematologist quickly to treat the patient as soon as possible, so that because many patients in the first 3 days, if not treated quickly, they might die from BIC. So this is a AML with some more, the leukemic cells have more cytoplasm, and then folded nuclei, and then this is actually a more monocytoid structure. And then flow cytometry, this is what I call a very sophisticated flow for AML, but may not be badly needed, because we usually, once we're dealing with this, so they're not providing too much additional information. For instance, for this one, we're gating, they're not in the blast gate, they intend to be in the monocyte gate. And then they have a spectrum of expressing many things, but most importantly, they expressing CD7, CD56, and also the monocyte marker, they're CD36 and CD36 and CD64. Once they express both, they're indicating monocyte, and then they appear to be more mature, because the immature will usually be more dim on the CD36. And then sometimes they partially express CD7 or sometimes CD2. So occasionally make it confusing to be confused with a T-cell type of a lymphoma or leukemia. So that's pretty much the kind of a quick walkthrough of what we have, what we can do by flow cytometry. And And also, we discussed the potential roadmaps in the future. So, and then welcome any questions from the group.
Thank you. Thank you, Dr. Chen. We can hold the questions until the end after both speakers, all three speakers. Appreciate it very much. A fantastic overview of flow cytometry, the principles, a little bit on the technical aspects, and the clinical application, as well as the roadmap. Actually, for me, the most interesting thing that you talked about, the roadmap, is how he broke it down in different journeys to make it very successful. Because as you can see, I'm sure most of you saw this presentation and said it's very overwhelming, it's extremely technical, it's too many numbers, and it can be. However, he already has done his homework. He knows what kind of flow cytometry is already available in the institution at St. Paul. But just to hit home how flow cytometry is incredibly important for the world of hematology. If you have a hematology and pathology, oncology fellowship, and if the blasts don't have any granules or our rods by morphology, the pathologist cannot tell the clinician whether this is acute myeloid leukemia or acute lymphoid leukemia, and they cannot give chemotherapy. You cannot treat without knowing whether it's AML or ALL. And that's where the application of the flow cytometry comes in. And the beauty of the roadmap that Dr. Chen showed is that that's actually the easiest one to start with. The most critical information is the easiest one to start with. So that's number one. The second thing, the second road, and to me, honestly, that's something I want you to be very excited about, to say this is going to solve a huge problem in terms of treating leukemias. The second roadmap that he gave, as for the world of lymphoma, the types of lymphoma diagnosis is very broad. And the difficulty with flow cytometry is both technical, but also financial. Those antibodies are very expensive, incredibly expensive. So the way he showed it, how to triage, the most important thing is going to be on the type of lymphomas that you guys see here. So if you say we see CLL patients, the panel can be adjusted for that. So I think the roadmap was absolutely wonderful, Dr. Chen. I thank you for that.